Welcome back to SurgiSmart Cut to the Core podcast. This is the deep dive, the show where we take the source material you send our way, the articles, the clinical notes, all of it, and we really dissect it to pull out those critical, actionable insights for you.
And today, we are focusing on a system that looks deceptively simple on the surface, but is just incredibly complex in how it actually works. We're talking about the esophagus.
Right. And this deep dive is so necessary because if you don't understand the failure modes, diagnosis becomes almost impossible.
Exactly. So our mission today is to really unpack that intricate anatomy, get our heads around the, let's be honest, challenging world of the Chicago classification.
It's a beast.
It is.
Yeah.
And from there, we'll do a detailed, very technical examination of the key motility pathologies. We'll be putting a special focus on achalasia and the modern tools we use to define it.
Okay, let's unpack that journey then, starting right at the beginning. We're tracing the path your food takes from the mouth down to the stomach, the esophagus.
It's a muscular tube, roughly, 25 centimeters long? But like you said, it's the orchestration, the movement within that tube that is the real marvel here.
It's so much more than just a simple pipe.
Oh, absolutely. It is far from being a passive conduit. Its sophistication is all about its ability to transport food through these highly coordinated sequential movements.
I like to think of it as a biological conveyor belt.
That's a great analogy. A conveyor belt that has to operate with absolute precision. The second that coordination breaks down, or maybe the pressure at the exit gate fails to relax.
That's when you enter the world of motility disorders.
Precisely.
And to make sure everything flows one way and, to prevent anything from coming back up, the esophagus has two critical gatekeepers.
Two sphincters, yeah. And they're functionally very distinct, regulating traffic at both ends.
Let's start at the top.
Okay, so at the top, regulating the entrance from the pharynx, you've got the upper esophageal sphincter, the UES. Now, this sphincter is primarily made of striated muscle.
Skeletal muscle. So that means it's under more voluntary control, in a way.
Exactly. More voluntary control, even though, it operates reflexively most of the time.
So what's its primary directive? I feel like it gets overlooked a lot compared to the LES.
It really does. And its main job isn't even managing the flow of food, though it definitely participates. Its primary, absolutely critical function is to prevent air from getting into the stomach while you're swallowing, or even just breathing.
Ah, okay. So if that's compromised, that's where you might see issues like globus or a lot of belching.
That's the connection, yes.
And then at the other end, down by the stomach, the high pressure zone we always hear about, that's the lower esophageal sphincter, the LES.
Yep, the one responsible for preventing reflux.
The critical one.
It is. The LES is the smoother, involuntary operator here. It's made entirely of smooth muscle, and it has this crucial baseline tonicity.
A constant, gentle squeeze.
A resting pressure, exactly. And that constant contraction is what keeps all that highly acidic stuff from the stomach from refluxing back up into the esophagus.
So if that baseline tonicity is shot, you've immediately got heartburn, potentially chronic reflux disease.
You've got it. The second that pressure drops too low, or if the LES just relaxes when it shouldn't, that harsh acid environment gets to bathe the very sensitive esophageal lining.
And it's also really important to realize that the muscle itself, the actual tissue in the body of the esophagus, it changes halfway down. It's not one continuous type.
And this transition is absolutely foundational to understanding the pathology.
Yeah.
It tells you which diseases affect which segment. The body of the esophagus, it starts with that striated muscle in the top portion, the proximal part.
Right.
And then it gradually transitions to purely smooth muscle in the distal portion, usually right around the mid-esophagus.
And no matter the muscle type, they're always organized in those two classic layers, right? The outer longitudinal and the inner circular.
Yes, and the coordinated function of those layers is, well, it's everything. The inner circular layer narrows the tube, and the outer longitudinal layer shortens the segment.
Which gives us peristalsis.
The crucial mechanism, peristalsis. It's this sequential wave-like contraction of these layers. And the key word there is sequential. The timing has to be perfect, running from top to bottom.
And that's where it gets really interesting because that perfectly sequenced propagation is what pushes everything forward. It ensures food moves efficiently, one way, towards the stomach.
And if that sequence is lost, or if the pressure wave is, say, simultaneous instead of sequential,
the whole transport function just fails.
It fails. And that loss of sequencing, that right there, is the definition of so many of the motility disorders we're going to get into today.
Okay, so we've set up the perfect system. Now let's talk about how we classify things when they go wrong. The sources you sent lay out a really clear framework. starting with this fundamental divide, primary versus secondary causes.
And this distinction is paramount.
Mm.
It dictates your entire diagnostic workup from the get-go. Primary disorders are diseases that come from the esophagus itself. They're intrinsic. The problem is localized to its muscles or, more often than not, its nerves.
And achalasia is the textbook example of a primary disorder.
It's the classic case, yes.
So what about secondary phenomena? This is where the esophagus is just, what, an innocent bystander?
That's a perfect way to put it. These are cases where the esophageal dysfunction is just one part of a much broader systemic disease that's affecting the whole body.
So trying to treat just the esophagus is pointless.
Completely pointless. You have to treat the systemic disease to have any hope of improving or even just stabilizing the esophageal symptoms.
Okay, give us a few concrete examples of those systemic hits.
Key ones would be Chagas disease, which is endemic in parts of South America. It's from the parasite Trypanosoma cruzi. It basically targets and destroys neuromuscular tissue everywhere, including the myoteric plexus of the esophagus. It often leads to a secondary achalasia.
Okay.
Then you have progressive systemic sclerosis, or PSS. Most people know it as scleroderma.
Right, where the body replaces healthy tissue with scar tissue.
Exactly. It replaces healthy, smooth muscle with dysfunctional, rigid, fibrous scar tissue.
And you also mentioned pseudoachalasia. That sounds like a perfect mimic, a real trap.
It is the great masquerader. Pseudoachalasia can present with symptoms and sometimes even manometry findings that look exactly like true primary achalasia. But the cause is extrinsic. It's usually a tumor or some inflammatory process pressing on the distal esophagus or infiltrating the EGJ.
And you have to rule that out because the treatment isn't a myotomy.
The treatment is oncology. It's a whole different ballgame.
So beyond the root cause, the source material also classifies these problems based on where the symptom is felt, which gives us a huge clinical clue. Oropharyngeal versus esophageal dysphagia.
Yes, so oropharyngeal dysphagia, where the problem is located way up high at the pharynx or the UES, that's typically related to more global neuromuscular diseases.
Things like a stroke or Parkinson's or ALS.
Exactly. The problem there is often about difficulty initiating the swallow safely in the first place.
And the symptoms are really distinct from what we think of with esophageal issues.
They are. With oropharyngeal dysphagia, the patient might complain about coughing, choking, maybe drooling, or food coming back up through their nose nasopharyngeal regurgitation the second they try to swallow.
Whereas esophageal dysphagia, which is where we're focusing, that's in the mid and lower esophagus.
Right, and that tends to show up as a feeling of food getting stuck or lodging in the chest, sometimes with chest pain or heartburn.
And this is where we hit a real crisis point, according to the epidemiology data you shared. The severity of the consequences here, it's just staggering.
We cannot ignore this. The numbers are, frankly, alarming, and they point to a huge and growing public health burden.
Estimates for dysphagia in people over 50 years old are somewhere between 16 and 22%.
And while the true primary esophageal motility disorders are rare, the vast majority of that 16 to 22% is related to oropharyngeal dysfunction, often from aging or neurological problems.
And the consequences are just, they're so severe. This isn't about comfort, it's about survival.
It really is. Untreated oropharyngeal dysphagia leads pretty quickly to dehydration, malnutrition, and crucially, aspiration.
Food or liquid getting into the lungs.
Which frequently results in aspiration pneumonia.
And the impact in places like hospitals and nursing homes is devastating.
It's a huge challenge. Up to 13% of all hospitalized patients have feeding problems. And that number leaps to a staggering 60% of nursing home residents.
60%.
60. And the mortality data really underscores the challenge. For nursing home residents who get dysphagia that leads to aspiration, the one-year mortality rate can be as high as 45%.
45%, that's a coin flip.
It is. Recognizing and managing this is not just a clinical detail, it's a life or death scenario. And with our aging population, this crisis is only going to get bigger.
Okay, so we've established the massive scope of all swallowing problems. Let's narrow our focus back now to the true primary motility disorders, the intrinsic diseases. Our sources list 4 main categories that manometry is really designed to pin down.
These are the core neuromuscular dysfunctions. First, you have achalasia, which is the main focus of our deep dive. Second, distal esophageal spasm, or DES.
Okay.
Third is hypercontractile esophagus, which you might know better as jackhammer esophagus.
Right.
And fourth, hypertensive LES, also known as nutcracker esophagus. These are the diagnoses that depend entirely on those precise measurements from high-resolution manometry.
But before we jump to a motor disorder, we always have to check for structural or mechanical issues that can mimic the symptoms.
Always. These can be intrinsic, inside the wall, or extrinsic, pushing on it from the outside.
So intrinsic examples.
Things that narrow the tube from within. So we look for malignancies like carcinoma or benign things like eosinophilic esophagitis, Schottky rings.
A thin membrane causing a narrowing.
Yep. Or peptic strictures from chronic acid damage.
And then the extrinsic ones, the things pushing on the esophagus from the outside that you could so easily miss if you don't do cross-sectional imaging.
Right, so that includes things like a mediastinal mass, could be benign, could be malignant, spinal osteophytes.
Bony spurs from the spine.
Exactly. Growing right off the vertebral column and impeding the swallow. Or even vascular compression from an artery that's in the wrong place.
The functional result is the same dysphagia, but the intervention is completely different. It's mechanical.
Which is why a comprehensive workup is mandatory. You can't skip steps.
All right, let's turn now to the pathology. Let's get into the deep dive on achalasia. Given its progressive nature and, well, its relatively high prevalence, it's the one we know the most about.
It is. It's a chronic condition, and we know its trajectory pretty well. Modern estimates put the incidence at about 2.9 new cases per 100,000 people in the U.S. each year. It typically shows up between the ages of 25 and 60, and it affects men and women equally.
The prevalence, though, is much higher because it's a lifelong disease, isn't it?
It is. The sources cite an estimate that suggests prevalence could be as high as 76 per 100,000. This is a disease patients live with for decades, and it requires chronic intervention.
So what are the defining characteristics? What is the clinical and manometric heart of the diagnosis?
Okay, there are two. First, the failure of the lower esophageal sphincter, the LES, to fully relax when you swallow. That leads to an outflow obstruction,
A blockage.
a functional blockage, and second, aperistalsis, which means a complete sustained loss of that coordinated smooth muscle movement in the body of the esophagus.
So why? Why does the LES fail to relax, and why does the body stop moving? This takes us right back to the nerves, doesn't it?
It's purely a neurological problem that affects the smooth muscle segment. Achalasia is the result of damage to the innervation. Specifically, a profound loss of inhibitory ganglion cells within the myenteric plexus.
The Auerbach plexus.
The Auerbach plexus, yes. These ganglion cells are the local nerve centers that govern the timing and sequence of muscle contraction and relaxation.
And if we dig down to the neurotransmitter level, what are we actually losing here?
We're losing the off switch. The primary inhibitory neurotransmitters in this plexus are nitric oxide, NO, and vasoactive intestinal peptide, or VIP.
NO and VIP.
And it's the neurons that produce NO and VIP that are destroyed early in the disease. These neurons have two very specific jobs: signal the LES to relax open when food is coming, and mediate the precise sequential timing of that peristaltic wave.
So if you lose NO and VIP, the smooth muscle is just constantly getting excitatory signals from acetylcholine without the countersignal telling it to chill out.
That is exactly it. The LES stays contracted because the relaxation signal is gone. And the peristaltic wave just breaks down into these useless, simultaneous or high-pressure contractions because the fine-tuning mechanism has been destroyed.
And this destructive loss of ganglion cells actually parallels how long the person has had the disease and what stage they're in.
It does. Which leads us directly into the modern Chicago classification types.
This is a point that our sources really emphasize needing a deeper explanation. We can't just list the types. We need to get into their clinical and prognostic implications. So let's define the Chicago classification types of achalasia.
Okay. The Chicago classification is our modern language for defining motility. For achalasia, it's divided into three functional types. All of them share that cardinal finding of a failed LES relaxation, which we quantify as an elevated integrated relaxation pressure, or IRP.
All right, start with type 1.
Type I achalasia is sometimes called classic achalasia. It's the simplest presentation.
Yeah.
You have complete aperistalsis, no movement at all, and a high IRP. This really represents the end stage of nerve destruction. The esophagus is often dilated, it's flaccid, and it just fills up with stagnant food.
Okay, now type 2. This is the really interesting one clinically because it has the best outcome.
It does. Type 2 achalasia is defined by panesophageal pressurization. So instead of a coordinated wave, the entire esophageal body pressurizes all at once to a high level with every swallow.
A chaotic but forceful contraction.
Very forceful against that closed LES. And crucially, studies have shown that type 2 responds significantly better to any kind of intervention, Botox, dilation, myotomy, you name it, than type I or type 3. They have the best prognosis for symptom relief.
But why? Why do they have the best prognosis if the nerves are still damaged?
Well, the hypothesis is that in type 2, the myenteric plexus isn't completely wiped out yet. It's more that the excitatory nerves are hyperactive or the inhibitory signals are just dysfunctional. This leads to that violent global squeeze. And because the muscle can still generate a high-pressure force, any intervention that reduces the LES resistance, even just temporarily, gives the muscle enough power to push the food through.
Okay, that makes sense. And finally, type 3 or spastic achalasia. This is where the lines start to blur a bit with the other spastic disorders.
They do. Type 3 is defined by having at least one premature, vigorous contraction. So the contractions are simultaneous and they have a short distal latency, or DL. This is often coupled with a very high distal contractile integral, the DCI.
So a highly uncoordinated, painful contraction.
Very. And unfortunately, type 3 typically has the worst response to non-surgical therapies. It often requires the most aggressive management, things like POM or a surgical myotomy.
So that progression model from outflow obstruction, maybe to type 2, then to type 1 with type 3 as this sort of parallel spastic form, that gives us a real clinical map. Now let's go back to the etiology. If the body is destroying its own nerve centers, what's the trigger? We mentioned autoimmunity.
Right. There's increasing evidence that points toward an autoimmune process in people who are genetically susceptible.
Yeah.
The idea is the body mistakenly attacks its own esophageal nerves, maybe through something called molecular mimicry.
And the sources mentioned herpes simplex virus type 1, HSV1, as a possible environmental trigger.
Yes. It's been proposed as one of the things that might kick off this destructive cycle in people who are already predisposed.
And what about that rare but really illuminating genetic link? The AAAS syndrome. It connects the esophagus to 3 completely separate systems.
Adrenal insufficiency, alacrima, which is a lack of tears, and achalasia. Yeah, this autosomal recessive genetic syndrome really highlights the deep systemic nature of autonomic failure. It's caused by mutations in the AAAS gene, which codes for a protein called eladin. Eladin is integral to how the nuclear pore complex works, which basically regulates traffic in and out of the cell nucleus. When eladin is defective, you get widespread autonomic nervous system dysfunction all over the body.
Affecting the adrenal glands, the tear glands, and the esophageal nerves.
Exactly. It shows that the basic cellular machinery for keeping nerves healthy is compromised at a fundamental level.
Okay, let's move away from the relative clarity of achalasia and into the murkier world of the spastic disorders. These often feel like diagnoses of exclusion, starting with distal esophageal spasm, or DES.
DES is an entity that is exceedingly rare. It gets blamed a lot for non-cardiac chest pain, but the vast majority of those cases end up being diagnosed as either reflux disease or, as we just discussed, type 3 spastic achalasia.
Manometrically, how does the Chicago classification pinpoint DES?
The cardinal abnormality for DES is the presence of premature contractions. Manometrically, that translates to a reduced distal latency, a DL of less than 4.5 seconds in more than 20% of swallows.
But with some preserved peristalsis.
Critically, yes. With preserved, albeit chaotic, peristalsis in the rest of the swallows. It means the timing is off. The contraction starts too quickly, leading to an uncoordinated squeeze.
But the underlying pathophysiology is still a black box compared to achalasia.
It really is. The neuromuscular pathology is unknown, and we don't have any consistent risk factors. What is often striking, though, in autopsy reports is the physical change in the esophageal wall itself. You see this diffuse muscular hypertrophy or hyperplasia, making the distal esophagus significantly thickened, sometimes up to 2 centimeters.
Which suggests the muscle is just trying too hard, maybe compensating for some intermittent neural problem.
That's one theory, yes.
That idea of muscle overreaction leads us right to the hypercontractile esophagus, jackhammer esophagus. This is just pure excessive force.
It's the definition of power gone wild. Jackhammer involves these extraordinarily vigorous esophageal contractions, but, and this is crucial, these contractions have a normal distal latency.
So the timing is right, the sequence is right, it's just the power that is way over the top.
Exactly. And we measure that power using a summary metric called the distal contractile integral, or DCI.
Right. And the threshold is 8,000. Let's try to make that number tangible for our listeners.
Okay, think of DCI as the total work or horsepower that the smooth muscle generates over a defined segment in time. It multiplies the amplitude of the contraction by its duration and the length of the segment. A normal swallow generates a DCI somewhere between 20 and 5,000 units.
And jackhammer is over 8,000.
Greater than 8,000 millimeter of HGCM-sec.
That's just massive. It's like putting a sports car engine in a bicycle.
That's a perfect analogy.
Yeah.
And this extreme hypercontractility is often associated with repetitive, multi-peak contractions and is almost always linked to symptomatic dysphagia and chest pain. If you see a DCI above 8,000 and the IRP and DL are normal, you have your diagnosis.
And finally, let's just revisit scleroderma. It's such a crucial example of a secondary motility disorder. It shows a structural, muscle-based failure, not a primary nerve failure.
Right. Progressive systemic sclerosis is a rheumatologic disease where you get excessive deposition of fibrous tissue. In the distal smooth muscle segment of the esophagus, this fibrous tissue gradually just replaces the muscle layer with rigid, non-functional scar tissue.
So it basically renders the muscle paralyzed and floppy?
Yes. The consequence is a gradual, irreversible loss of peristalsis and, critically, a profound weakening and functional loss of the LES.
Which leads to severe chronic GERD.
Exactly. And the really specific detail here is that the scarring is limited to the smooth muscle. The proximal striated muscle motility stays preserved.
Okay, let's move on to diagnosis. A patient comes in with difficulty swallowing or chest pain. The first step is always going to be the patient history. You have to be a clinical detective before you order any tests.
The history is the absolute cornerstone. We're looking for two paramount points. First, differentiating solids versus liquids. If they have difficulty with both solids and liquids right from the start, that suggests a motor disorder, a generalized failure of movement that doesn't care what the consistency of the food is.
But if it's difficulty with solids only, at least initially, that points toward a structural blockage.
Right. A solid-only problem is highly suggestive of a mechanical issue, like a stricture or a Schottky ring, because liquids can still get through that narrowed opening.
But we have to remember that structural issues can start to mimic motor disorders as they get worse.
They absolutely can, especially as the narrowing progresses.
And the second crucial challenge from the history is the patient's ability to locate the problem. You mentioned this is notoriously inaccurate.
It is remarkably unreliable, and it's a classic trap for new clinicians. A distal obstruction, whether it's a ring or achalasia, is frequently perceived by the patient as cervical dysphagia. They feel it lodging high up in their neck or throat.
The data suggests they only get it right about 60% of the time.
About that, yes.
So if a patient points to their throat and says, food is sticking right here, we can't just scope the UES, we have to investigate the whole length.
You absolutely must assume the problem is distal until you've proven otherwise. The entire esophagus has to be evaluated.
This objectivity leads us right into the frequent clinical confusion between true dysphagia and that subjective feeling of a lump, the dreaded globus sensation.
This is such a critical distinction for an efficient diagnosis. True dysphagia occurs only during the act of swallowing. It is a failure of transport. The food is actually getting stuck.
Whereas globus sensation is that persistent, constant feeling of having a foreign object caught in your throat.
And crucially, globus is prominent between swallows. We've used an analogy. Dysphagia is like a traffic jam. It only happens when a car is trying to pass. Globus is like a constant annoying speed bump you feel even when the road is completely empty.
That sensation, of course, is what led to the older term globus hystericus because it was linked to anxiety.
Well, that specific term is outdated and frankly pejorative. But the clinical link to anxiety is still relevant. Many patients with globus do report substantial generalized anxiety. And importantly, despite decades of study, we have generally failed to find any objective anatomic or physiologic cause for it. The history, the fact that it persists regardless of swallowing, is still the only reliable marker.
So before we commit to any advanced imaging, our differential diagnosis list needs us to rule out those serious mimics we talked about.
That differential is our safety net. If chest pain is involved, the number one priority is always ruling out coronary artery disease.
Always.
Then, for suspected motility disorders, we have to rule out secondary causes, Chagas disease, tumors causing pseudoachalasia, or even simple things like xerostomia dry mouth, which can mess with the swallow initiation. Only after those exclusions do we proceed.
Okay, let's get to the hard evidence. We'll start with diagnostic tool 1, esophagography, or what most of us call the barium swallow.
The barium swallow is often chosen first. It's non-invasive, it's quick, and it visualizes both anatomy, so you can see strictures or tumors and function. You can actually watch the flow.
It gives you a gross visual of the loss of peristalsis and where the contrast is pooling.
Exactly.
And the classic finding for advanced achalasia is what every resident learns on day 1.
The pathognomonic sign, the bird beak appearance.
The bird beak.
You see this dilated, air fluid-filled esophagus up in the chest, and it tapers down to this pencil point narrowing at the lower end because of the non-relaxing LES. You might also see epinephric diverticula, these little outpouchings right above the LES, which are caused by the high pressures in the esophagus.
And our sources noted a pretty common comorbidity with achalasia patients.
Yeah, there's a significant chance, about 10 to 20%, of a concurrent hiatal hernia in these patients, which complicates both the symptoms and any subsequent surgical planning.
And what do the spastic disorders look like on barium?
DES, distal esophageal spasm, can show that characteristic corkscrew or rosary bead appearance.
Right.
It reflects those simultaneous, non-sequential contractions squeezing the barium column in a chaotic way. Scleroderma, on the other hand, because of the loss of muscle tone, generally just presents as a flaccid, dilated esophagus with a lot of reflux and very weak or absent peristalsis.
Now we arrive at the gold standard for defining function. Diagnostic tool 2, manometry, and specifically high-resolution manometry, or HRM.
HRM has completely revolutionized our ability to classify these disorders precisely.
It really has.
It uses a catheter with numerous pressure sensors spaced really close together, which lets us create a real-time, three-dimensional topographical map of the pressure changes. We use these maps, they're often called close plots, the pressure heat maps, to quantify the force and the timing according to the Chicago classification criteria.
And HRM boils it all down to 3 core measurements to define the disorder. Let's review them again, starting with the marker for LES failure, the IRP.
Okay, the integrated relaxation pressure, or IRP. This is the first metric we always check. It answers the question, did the LES open? It measures the average pressure at the EGJ during the 4 seconds of greatest relaxation after a swallow. Normal is up to 15 mm of Hg. Anything above 15 means the LES isn't relaxing properly.
Which is the gateway finding for diagnosing achalasia.
It's the necessary first step, yes.
Second, the measure of timing, the DL.
Distal latency. This is a temporal metric. It measures the time from the start of the swallow to the moment the peristaltic wave hits the esophagogastric junction. Normal is up to 4.5 seconds.
And anything less than 4.5 seconds is premature.
It's the definition of a premature simultaneous contraction. So a reduced DL is the cardinal sign of the spastic disorders, like GES or type 3 achalasia.
And finally, the measure of pure force, the DCI.
The distal contractile integral. This quantifies the strength, the horsepower of the muscle contraction. It integrates the amplitude, duration, and length of the contracting segment.
And normal values are pretty wide, 450 to 5,000.
They are. Values below 450 mean you have a weak, ineffective swallow, like you'd see in scleroderma. And values over 8,000 define that hypercontractile or jackhammer esophagus.
So the Chicago classification is essentially a sequential algorithm. First, you check the IRP. If it's high, you're on the achalasia pathway.
That's the flow.
If the IRP is normal, you move on to check the DL and DCI to find the spastic disorders.
That is the precise flow. If the IRP is high, you immediately diagnose achalasia. Then you use the rest of the manometric data, the presence of pan-pressurization or spastic contractions, to categorize it into type 1, 2, or 3.
So let's nail down those manometry findings for the primary disorders using those metrics for achalasia.
The hallmark findings, no matter the type, are an abnormally high IRP, that failure to relax and aperistalsis or abnormal pressurization in the body. Manometry is definitive. It makes the diagnosis in about 90% of cases.
Okay, so how do we manometrically definitively separate DES from a jackhammer or a nutcracker esophagus?
So this is a nuanced point required by the classification. For DES, the required finding is the reduced DL. The timing is wrong. It has to show premature contractions, even if they are high amplitude.
Okay.
For the jackhammer esophagus, the required finding is a DCI above 8,000. But the DL must be normal. The contraction is excessively strong, but the timing is correct.
And the nutcracker esophagus. This one often gets mixed up with DES.
Right. Under the most recent classification, the nutcracker esophagus is often just grouped under the general heading of hypercontractile disorders if the DCI is over 8,000. Historically, it was defined by high amplitude contractions, so DCI over 5,000, prolonged contractions, and a high LES pressure, but with normal peristaltic sequencing. The key discriminator is maintaining that normal peristaltic pattern.
Okay. Finally, diagnostic tool 3. Endoscopy. It's often the first step, but it might not catch early motility disease.
Endoscopy is crucial because it's the only tool we have with both diagnostic and therapeutic significance. But you're right, it can be inconclusive in early disease because the big anatomical changes like massive dilation or retained food, they only happen late in the game.
So what are we actively looking for when we go in with the scope?
We're looking for indirect signs of stasis, so retained food or liquid in the esophagus or visible damage to the lining, and inflamed, ulcerated, or friable mucosa from chronic stasis esophagitis.
And its critical therapeutic role.
Its greatest strength is the opportunity to intervene right then and there. We can take biopsies immediately to rule out things like eosinophilic esophagitis or carcinoma.
And you can do interventions at the same time.
Exactly. You can do an initial Botox injection or even a dilation, making it a critical look-and-treat platform.
Okay, let's pivot to management. The principles here are grounded in a difficult truth about achalasia. The nerve damage is permanent. It's irreversible and therefore incurable.
That has to be the starting point for any patient counseling. Since the nerve damage can't be reversed, the mainstay of treatment is purely symptomatic control. We're mechanically or chemically reducing the pressure barrier at the LES.
And given the complexity, patients should really be managed at high-volume centers.
Absolutely. Centers with expert gastroenterology and surgical services are key.
For mild or early disease, pharmacological interventions can be a bridge, but they have some major limitations.
They do. Historically, we use nitrates and calcium channel blockers like Nifidat. They work by systemically relaxing smooth muscle, which includes the LES, but their efficacy is pretty limited and often short-lived.
And the side effect profile often forces patients off these drugs pretty quickly, doesn't it?
It does. While nifedipine can reduce LES pressure, getting a high enough dose to be effective often causes significant systemic side effects: hypotension, lightheadedness, severe headaches. These factors often limit long-term use and push patients toward more definitive therapies.
And we also have to address comorbidities like anxiety and GER.
For persistent reflux, we use standard PPIs, gastroprokinetics. And when anxiety is clearly a component, particularly in patients with functional chest pain or globus, low-dose TCAs or SSRIs are often used to help manage those symptoms and the visceral hypersensitivity.
When drugs fail, we move to endoscopic therapies, targeting that LES pressure. This is where we need to compare efficacy, risks, and durability.
Okay, there are three main endoscopic approaches. First, you have botulinum toxin injection. This is the least invasive. It's injected directly into the LES to chemically paralyze the muscle fibers.
So what's its role? Who gets Botox?
Botox is reserved primarily for poor surgical candidates, people who are too frail for a myotomy or a pneumatic dilation, and that's because its effects are temporary. They only last about 6 to 12 months.
So not a great primary treatment for a young, healthy patient.
No, the high relapse rate makes it unsuitable.
Next up, the mechanical approach, pneumatic dilation.
Pneumatic dilation uses a specialized balloon, the TTS pneumatic balloon, which is inflated to a very high pressure to intentionally tear the muscle fibers of the LES.
It has a higher long-term success rate than Botox.
It does. It often achieves relief for several years. The major drawback, though, is the risk of perforation. It's a low risk, but if it happens, it requires immediate surgical intervention, and it's a very serious complication.
And that brings us to the modern, game-changing endoscopic technique that's basically an internal surgical myotomy, POEM.
Peroral endoscopic myotomy. It has transformed the field. It's an advanced technique where an endoscope is used to tunnel down between the layers of the esophageal wall and surgically cut the circular smooth muscle fibers of the LES from the inside.
That sounds far more definitive than a balloon tear or a Botox shot. How does its efficacy compare?
POEM is highly effective. It matches the long-term success rates of a formal Heller myotomy. And for type 3 spastic achalasia, POEM is often preferred because it allows the surgeon to perform a much longer myotomy up into the spastic esophageal body.
Okay, but what's the downside?
The one significant downside is that because it's a pure muscle cut without a protective wrap, the rate of post-procedure reflux, or GERD, is often higher than a traditional surgical myotomy that's combined with a fundoplication.
And that distinction leads us right to the most definitive option: surgical care for the really refractory or severe cases.
The surgical cornerstone is the Heller's myotomy, usually done laparoscopically. This involves surgically incising the muscle fibers of the LES to permanently reduce that resting pressure.
And this is where that critical corrective step comes in, which our sources highlighted. You can't just cut the LES and walk away.
Absolutely not. This is a critical clinical detail. When you cut that high-pressure valve, which is what a myotomy is, you permanently eliminate the barrier to acid reflux. Therefore, every effective myotomy must be accompanied by a partial fundoplication, usually door or toupette fundoplication,
where a portion of the stomach is wrapped around the esophageal opening.
to act as an anti-reflux mechanism, yes. To prevent the devastating GERD that would otherwise happen after you've intentionally destroyed the LES,
If you omit that step, you're just trading achalasia for severe chronic erosive reflux.
which is equally damaging. And for true end-stage disease, a sigmoid-shaped, massively dilated, non-functional esophagus, the only option left is the most extreme, an esophagectomy.
All right, let's wrap this up with the prognosis. What should you expect long term?
For achalasia, the prognosis is defined by its progression. It requires chronic therapy, it requires intervention, and often re-intervention throughout the patient's entire life. Even with successful treatment, patients have to be constantly vigilant about their diet and need lifelong monitoring.
And for scleroderma esophagus?
The severity of the esophageal involvement is tied directly to how well the primary systemic illness is controlled. Because scleroderma is generally a progressive fibrotic disorder, these patients struggle with severe, often intractable, acid reflux.
Because the LES is just irreversibly weakened.
And non-functional, yes.
We ended our last discussion on a point of hope, but also caution for the spastic esophageal disorders.
Right. Generally, the prognosis for primary spastic disorders, like DES or jackhammer, is favorable. Patients can usually attain a good baseline status and can be managed effectively.
Right.
But, and this is a crucial, mandatory warning, worsening symptoms or a change in manometric parameters warrants an immediate, urgent workup.
Why?
Because these spastic disorders have a known propensity to progress. They can develop into full-blown type 1 or type 2 achalasia over time.
And that distinction, the chronic, guaranteed progression of achalasia versus the favorable but watchful status of spastic disorders, that's really the key insight here.
It is. And if we connect this to the big picture, mastering the diagnosis really requires integrating 3 levels of understanding. First, the basic anatomy smooth versus striated muscle lets you differentiate nerve-based diseases like achalasia from muscle-based diseases like scleroderma. Second, the clinical history helps you rule out all the mechanical or systemic mimics. And third, the precision of manometry lets you distinguish the timing, the DL, from the force, the DCI of the contractions. And that dictates whether you're dealing with a type 2, a type 3, or a jackhammer pattern, and therefore it dictates the exact management plan.
A truly comprehensive deep dive. So what does this all mean for the learner out there working with these patients? Our final provocative thought for you to consider builds on that progression point. Since spastic esophageal disorders have that propensity to develop into the lifelong chronic management required for achalasia, what are the most subtle early signs, those minimal shifts in manometric metrics or the slight changes in how symptoms present, that should trigger you to immediately reevaluate for progression from a favorable prognosis toward the chronic, irreversible state of achalasia?
And this really just underscores the importance of longitudinal monitoring and having a very low threshold for repeat manometry in these patients, even years after their initial diagnosis.
A fantastic deep dive into a system that governs so much of our comfort and our long-term health. Thank you for providing the source material for this analysis.
It's always a pleasure to cut to the core.
We'll catch you on the next deep dive.